Hello, thank you so much for being here today. My name is Aasma Shaukat, and I'll be talking about blood-based and imaging-based options for colorectal cancer screening. I'll review some recent trends in colon cancer incidence in the US, provide you some updates on evidence on colon cancer screening, think about how we can improve adherence, some current and future options for colorectal cancer screening, including some novel blood-based testing, and leave you with some take-home points. So this is the good news. Colorectal cancer mortality over the last few decades has continued to decline in the US. Much of this effect is from the contribution of colorectal cancer screening, along with improvements in risk factors and additional contributions from improvements in treatment. So this is a great trend and one we hope to continue. At the same time, we've also seen declines in colorectal cancer incidence for both men and women ages 50 and older over the last few decades. Again, a very encouraging trend that we hope to continue. You can see both the curves are pointing downwards, and we think this is largely due to the effect of screening. However, when we look at screening in or colorectal cancer incidence in younger individuals, so these curves represent men and women ages 20 to 49, we see that the incidence for colorectal cancer has relatively been stable over the many past decades, and there's been a recent uptick over the last few decades. And this is a trend that's been very concerning. So a lot of evidence has gone in the background, and it's culminated into changes in guidelines for all major societies. The American College of Gastroenterology, US Preventive Services Task Force, and the US Multi-Society Task Force are now completely aligned and recommend screening adults starting at age 45, with emphasis on ages 50 and older for sure, all the way to age 75. And after that, the decision to screen should be tailored. So the new screening age is 45. So let's see how we've been doing in the US. These are data from the Behavior Risk Factor Surveillance System in 2020 done by the CDC. And they essentially pick a random representative sample across the US and call individuals and ask them if they've been screened and which modality. So they asked about all the currently available modalities, and you can see these results by state. What's interesting is that across the US, we are not just one homogeneous number, and there's a lot of variation in screening rates that varies by where people live and even within states. You can see that the Northeast tends to do better in terms of higher screening rates because a lot of these states have state coverage for screening that's free of cost. And then in the South, particularly Southwest, the screening rates are lower. So if we average this entire checkerboard, we get a number of 68%, which is great. But it also means that 1 in 3 individuals who is screen eligible is currently not screened. When we look at a breakdown by race, whites and African Americans are 70% or higher screening rates, with Asians and Hispanics being lower than that. And this study also looked at what are the factors associated with not undergoing colon cancer screening. And the two largest ones that emerge are lack of health insurance and lack of a regular healthcare provider. The lack of health insurance is, again, as we know, kind of a national issue and one we need a lot of different efforts to get at. However, a lower hanging fruit is lack of a regular healthcare provider. These are individuals that have health insurance, but just don't either have a doctor or see a physician regularly. And that's something that we can definitely improve so that they can be offered screening and be encouraged to complete it. On top of these trailing rates, we've now added a storm of 21 million adults that are between the ages of 45 to 49, and they are now screen eligible, according to the new guidelines. So we really need some strategies on how to get everybody to improve colon cancer screening rates. So this begs the large picture question: what do we need to build? And who is truly our target that we need should come to these systems? And the answers are: we need systems that can bring in these newly eligible individuals to screening, those that are overdue, particularly during the pandemic. Preventative care fell to the wayside, so there's a lot of individuals that did not get their routine screening, and also individuals that have never been screened. We need to find how to get them to come to screening. We need to ensure we have adequate endoscopic capacity, and individuals have access to that endoscopic capacity. And all this needs to be done in a health equity framework so that both access and screening is equitable across many, many factors. Our goal is to get to 80% in every community. And we do need to realize that what got us to our current rates of about 68 to 70% may not be enough to get us to 80% in every community. And even states that have achieved higher rates, that doesn't mean that every community is at that 80% bar. So this is our challenge and something that we need to do as a community. So now we turn to what are our colon cancer screening options. There's many different options to pick from, but broadly they fall in the category of either colonoscopy or a stool-based testing. How to pick from these? Again, adherence is key. The best test is the one that gets done, so that's important to offer. I want us to think about colon cancer screening tests not as cancer detection or prevention, but rather, is it a one-step test, such as colonoscopy, or can we offer two-step tests, such as a stool, imaging-based, or blood-based test initially, and those that are positive then get a colonoscopy. So with this, I'll turn to some future trends and some novel testing strategies. So blood-based tests are now a reality. We used to only have colonoscopy or stool-based testing, but now there's a whole cadre of tests that can develop, that can detect cell-free DNA, glycoprotein, and other signals to tell us about large adenomas and early cancers. And just to give you a snapshot of the number of studies that have now been completed, there's 4 for blood-based tests and 1 that is both a stool and a blood-based test. They have all recruited somewhere between 6,000 to 25,000 individuals, and many have completed their studies and released their results. Garden released its results this year, and the test is 87% sensitive, 90% specific for colon cancer, and sensitivity for advanced adenomas is at 12%. So these are important tests that are in front of the FDA and Medicare for approvals. And this is what Medicare says about approvals. Medicare will cover or pay for a blood test every 3 years if it meets these criteria: 74% sensitive for cancer, 90% specific, and FDA approved. Data that I showed you for Guardant already meets these bars, and the company is likely seeking FDA approval now. So this does raise some very practical questions. How do we envision the test being ordered? How will it be completed? How will it be collected for optimal completion? Where will it be processed? How long will it take to get results? Who will have to interpret the result? Will it always be a clinician, staff, or can it be released to the patient? And how will we ensure that if the test is positive, a colonoscopy is done? And I'd love to talk about these questions and others during our question answer session. One thing we do know, at least from some pilot studies, is that blood-based testing seems to be more acceptable. In this particular study, when individuals were offered either a FIT or a blood test randomized to one or the other, the adherence or the uptake or completion of the blood test was about 10 percentage points higher than for the stool test. So these data give us hope that having a blood test will hopefully allow us to boost that number to 80% or higher, which is our goal. So in summary, there's some novel blood-based tests that are in development and have completed their pivotal studies and are seeking approvals ready for clinical practice in the next year. There's also some image-based tests, such as colon capsule and a CT capsule that can detect polyps as well as cancers, and even an MR colonography-based test that is under development. We think all these non-invasive options will enhance our offerings for colon cancer screening and hopefully improve adherence, which is our underlying goal. So in summary, screening for colorectal cancer is effective. Our current national rates are about 70%, with many communities being much below that number. We need programmatic approaches to identify the unscreened, and then ways to bring them to screening with the emphasis on adherence, meaning the best test is the one that we can offer and get completed. In this realm, new blood and imaging-based options are under development and show a lot of promise to be ready for clinical use in the next year. With that, I'd like to thank you for your kind attention, and I'm looking forward to the question-answer section. Thank you.